You know, thrombolysis coding trips up even the absolute most experienced medical coding pros out there. And you might be wondering, why? Well, it's because unlike the vast majority of procedures we deal with, it isn't billed just once per intervention. No, it is billed per calendar day, and that treatment can sometimes span across multiple consecutive days. This fundamental shift in logic is exactly where the denials happen, and it is exactly what we are going to fix today. So in this explainer, we're going to break down how to master these codes, ensuring your claims are clean, compliant, and of course, correctly reimbursed.
Okay, let's dive right into this. Here is our roadmap for the explainer. We'll start with the challenge itself and the foundational rules. Then map out the core timeline, jump into some real-world examples, tackle modifiers in Medicare, and finally, look at the cerebral exception.
All right, starting things off with Section 1, the Thrombolysis Coding Challenge.
To really get these codes, we kind of have to understand the clinical reality of what's happening in the room. Catheter-directed thrombolysis is an intervention where a physician guides a catheter directly into a vessel to deliver a clot-dissolving medication, usually TPA. But here is the key thing to remember. Clots just don't vanish instantly, right? The medication has to be infused gradually over time. And because this treatment frequently continues over 2, 3, or even literally more days, CPT created a set of codes built entirely around treatment days rather than a single procedural encounter.
Moving right along to Section 2, let's lay down some foundational coding rules.
So, before you even touch a specific code, you absolutely have to know what is already included in it. Think of your daily thrombolysis code like a container that bundles in a lot of specific work. Same-day evaluation and management visits related to the procedure, bundled. Follow-up angiograms during the infusion, bundled. Catheter repositioning or exchanges on that same day. Yeah, that's bundled too. But, and this is super critical, this container does not include the initial catheterization, the initial diagnostic angiography, or ultrasound guidance for vascular access, like code 76937. Those initial setup steps are billed completely separately when they are properly documented.
And this brilliantly illustrates our next point in Section 3, the core code timeline.
All right, let's actually walk through this chronological timeline. Day 1 is your initial treatment day. You'll use code 37211 for arterial or 37212 for venous. Now, if that infusion goes into a second, third, or even fourth day, those become what we call your middle days. For literally any day that is not the first day and not the last day, you're going to report 37213. Finally, when the treatment ends, the catheter is pulled and the vessel is closed up, you report 37214 for cessation on that final day. Now, a very quick note here. If the thrombolysis happens to start and end on the exact same calendar day, you only report that initial day 1 code. You do not need to add the cessation code.
Let's see how this all plays out. Section 4, real-world coding examples.
Let's move to and see how this builds in practice by comparing a 2-day procedure against a 3-day procedure. On day 1, for both of these scenarios, you have your initial catheterization, your diagnostic codes, and your initial thrombolysis code, 37211. Simple enough. But look closely at day 2. If the treatment completely stops on day 2, your code is 37214 for cessation. However, if the infusion continues through day 2, well then it becomes a middle day, coded as 37213. It's not until day 3 that we finally report 37214. As you can see, the code completely shifts depending solely on whether the calendar day is a middle day or the final day of treatment.
Now, things get significantly more complex when we have multiple legs or vascular beds involved. Because remember, thrombolysis codes are unilateral. If a patient gets arterial thrombolysis in both legs starting on a Monday, you just use modifier 50. Easy. But what if the left leg stops on Tuesday while the right leg keeps going? Well, then you build cessation 37214 for the left and continued treatment 37213 for the right. Or let's look at a venous example. Say you start the right leg on Monday, stop it on Tuesday, but then start the left leg on Tuesday. You'll literally be billing a cessation code for the right leg and an initial code for the left leg on the exact same day. You have to track each extremity's timeline completely independently.
Which brings us to a major trap for coders. Section 5, Modifiers and Medicare Limits.
Listen, Medicare has highly specific National Correct Coding Initiative, or NCCI edits. You generally cannot bill initial codes together with continued or cessation codes on the same leg on the same day. It'll get flagged. When you do have valid concurrent treatments, modifiers are your absolute best friend. You must use modifier 50 for bilateral thrombolysis done through separate accesses. But if you are treating 2 entirely separate vascular beds, like say a renal artery and a femoral artery, you must append modifier 59 instead, just to show they are distinct and separate procedures.
So, the crucial point here really boils down to this number. 1. All 4 core thrombolysis codes have a medically unlikely edit, or MUE, of 1 per day. Medicare simply will not pay for the same code twice in a single day. No way. If you try to bypass this by billing 2 separate lines with RT and LT modifiers, Medicare will flat out deny all the line items. You must bill it on a single line with modifier 50.
And why is it so important to get that modifier 50 right, instead of just getting denied? Because properly documenting bilateral necessity and using modifier 50 yields a 150% reimbursement on the Medicare physician fee schedule. So getting those modifiers right doesn't just prevent those incredibly frustrating denials, it ensures your practice is fully and fairly compensated for all the complex work being done.
Finally, we need to address the big outlier. Section 6, the cerebral exception. You must never, ever mix body codes with brain codes. Codes 372111 through 372114 are specifically for outside the brain, period. If the physician is performing cerebral or intracranial thrombolysis, you are looking at an entirely different rulebook. If it's a cerebral IV infusion, which is typically started down in the ER for a stroke, you use 3795. But if it's an intracranial mechanical thrombectomy or a targeted catheter infusion, you use code 61645. And here is why 61645 is so drastically different from our body codes. Remember how earlier we talked about that container and how initial catheterization and diagnostics were billed separately? Yeah, not here. 61645 is an all-inclusive complete code. It bundles pretty much everything together. The vascular catheterization, the diagnostic angiography, all the fluoroscopic guidance, the neurologic monitoring, the closure, and the procedure itself. It is a massive, comprehensive code.
Furthermore, instead of being bound to a calendar day like the body codes, 61645 is bound to vascular territories. CPT specifically defines 3 intracranial territories: the right carotid circulation, the left carotid circulation, and the vertebrobasilar circulation. You report 61645 only once per defined territory, regardless of how many individual arteries within that specific territory the physician had to treat.
Well, we have covered a whole lot of ground today, from the daily containers of the body codes to the strict NCCI edits of Medicare, and finally, the comprehensive, all-inclusive nature of the cerebral codes. The real key takeaway here is realizing that thrombolysis coding requires a totally different mindset than almost anything else you do. So I'll leave you with this. Are you ready to stop billing thrombolysis by the procedure and start mastering the calendar day? Keep this timeline logic front and center, use your modifiers correctly, and for sure, you'll be coding these complex cases with absolute confidence. Thanks so much for joining me on this explainer, and keep learning.